Peace. Welcome to the YouTube live book reading. I just had the pleasure of stopping back through the last reading and I saw for some reason the ending is completely cut off. I mean, it was like the last 6 minutes. So this is one of those retakes. Happy Wednesday and welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, Carole A. Trout, and I'm your moderator and narrator, Uriel Riley. So we're going back into 60 again. This is the 60th take 2 episode of this book reading. So here we go. I don't know what happened. All we know is we're about solutions on this channel, on this peaceful part of YouTube where we read books and learn from masters. So chapter 23 begins here. We want to give a shout out, elevation of the great D'Angelo. Yesterday I was giving him the tribute, and I guess something happened from there. Love you. All you've done for us and given us beautiful art lives. Peace, YouTube. All right, here we go. Chapter 23, Principles of Ventilator Maintenance. Take 2. The maintenance of mechanical ventilation is a multidisciplinary challenge. The respiratory therapist is the cornerstone of this care, since proper use, control, and maintenance of the ventilator and artificial airway are essential. The respiratory intensive care nurse plays an equally vital role in being responsible for bedside monitoring, physical care, and delivery of medications. The chest physical therapist augments the efforts of the respiratory therapist and nurse in maintaining bronchial hygiene. Respiratory intensive care demands moment to moment monitoring and therapy 24 hours a day. The routine changeover of personnel every 8 hours requires established procedures and an excellent system of communication. There are numerous ways to accomplish good care. The essential fact is that the critical care unit must have a specific standard operating procedure that is understood by all who participate in patient care. Thank you for being here. Peace, YouTube. This assures smooth continuation of care from shift to shift and day to day. Unfortunately, inherent in this approach is the necessity for an established program. Therefore, the individual preferences of specific physicians, nurses, and therapists cannot always be catered to. It is not our intention to put forth specific operating procedures of ventilator care. Rather, the purpose is to discuss the principles necessary for development of a clinically sound procedural program. The following discussion must not be interpreted as espousing the way to accomplish ventilator maintenance. Instead, it should be considered a discussion of the physiologic and medical principles that must be satisfied by an acceptable procedure. Discussion of specific procedural methods is avoided where possible. However, in some circumstances, it is necessary to describe specific procedures to clarify the discussion. The reader must understand that when such circumstances exist, our standard procedure is presented as an example, not as the only way the goals can be accomplished. All right. Yupnik, ventilation. Peace. Welcome. Thank you so much. Yupnik. Ventilation is the maintenance of an arterial PCO2 within a normal range defined classically as PCO2 between 35 and 45 millimeters Hg. The concept of normal ventilation should incorporate the principle of supporting the ventilatory state in the range normally maintained by that patient. A patient who normally carries an arterial PCO2 of 70 millimeters Hg should be ventilated at an arterial PCO2 close to 70 millimeters Hg. Peace, highest heart love. Welcome, exalted. Highest heart love. Thank you so much for being here in the peaceful part of YouTube where we read books and learn from masters. And right now, we just are beginning again on the 23rd chapter. This is take two. So we're at the top of page 350, going into acid base abnormalities. The reasons for maintaining normal ventilation are primarily acid, base, and electrolyte considerations. If an individual is maintained at an arterial PCO2 significantly different from his or her normal range, acute alkalemia or acidemia will result. The kidneys will appropriately respond by holding on to or getting rid of base HCO3. Normal kidneys will metabolically compensate for a ventilatory pH change in 24 to 36 hours. For example, an individual who normally carries an arterial PCO2 of 70 millimeters Hg and a pH of 7.40 is in a state of compensated respiratory acidosis, chronic ventilatory failure. Mhm. An increased amount of base HCO3 is present. That's very key. If this individual is suddenly ventilated to and maintained at PCO2 of 40 millimeters Hg for several days, the kidneys will excrete the excess base to correct the sudden respiratory alkalemia. That's right. See, the body always wants to be balanced, so it will figure out a way to balance out. And this is a perfect example. The previously described process causes two major problems. The cardiovascular and hepatorenal and central nervous systems will be challenged to function adequately in an alkalemic milieu and its associated electrolyte environment for several days. Not only is cellular membrane function compromised, but sensitivities and reactivities are various drugs are less predictable. The goal must be acid base stability from the moment the patient is placed on the ventilator. Right. Ding! That's right. When we can help ourselves and master ourselves, we can help others heal, right? That's what this channel is for. The Healer's Corner, the Master's Corner of YouTube. And so I honor you. Thank you so much for being a reflection of the divine. That's why you're here. The highest heart love. It is written. The previously, yes, the cardiovascular. All right. Two, when the ventilator is removed from the patient and he or she assumes total spontaneous ventilation, she or he will be required to breathe at an alveolar ventilation far greater than her or his pre-existent baseline state. If she or he assumes his or her previous baseline arterial PCO2 of 70 millimeters Hg, she or he will become acidemic, secondary to the acute CO2 rise and the inability of the kidneys to immediately reacclimate biocarbonate ion. The acute acidemia acts as an additional challenge to her or his limited cardiopulmonary reserves. Not uncommonly, the patient will end up in severe respiratory and cardiovascular distress because of her or his inability to maintain ventilation above his or her normal baseline state. This generally results in the patient being placed back on the ventilator and considered a weaning problem. Note that the problem is strictly a result of the improper ventilator maintenance. Top of page 351. In addition to the acid base problem, acute alveolar hyperventilation will result in cerebral vasoconstriction in response to the decreased arterial PCO2. In most circumstances, this leads to a decreased cerebral blood flow. This may be desirable for short periods of time in acute head trauma. See Chapter 34. However, in the critically ill patient without brain damage, this decreased blood flow to the brain may be disastrous. There are and has been much speculation that CNS embarrassment may be the key to major complications confronted in ventilator care. It is theoretically detrimental to routinely maintain ventilator support at arterial PCO2 levels below a patient's pre-existing baseline. Oh, another solution. Middle of page 351. Peace. YouTube, thank you so much to the book lovers community. Highest heart love to all my friends and family, all the healers out there, nurses, M techs, rep techs, OR techs. We love you so much. Highest heart love and honor to all the October birthdays as well. Dead space tubing technique. Many patients in the early part of their ventilator course will require control mode ventilation, CMV. Some patients, for a significant period of time, the optimal IPPV pattern in control mode may result in undesirably low arterial PCO2s. In this circumstance, it is necessary to have a means of manipulating the arterial PCO2 so that Yupkania, uh, Upenic may be maintained in conjunction with the appropriate ventilator pattern. The addition of dead space tubing is the process of placing a volume of tubing between the artificial airway and the Y piece of the ventilator. This extension of the trachea results in rebreathing of expired gas and therefore increases the inspired carbon dioxide concentration. That would be the result exactly. Ding! Therefore increases carbon dioxide inspired concentrations. The respiratory care practitioner must remember that dead space tubing will both increase carbon dioxide inspired concentrations and decrease oxygen concentrations reaching the alveoli. The latter effect is minimized with proper oxygen therapy. Nomograms are available for estimating the degree of dead space tubing required. However, we have found that simply titrating additions of 50 to 100 milliliters volumes of tubing is the fastest and most reliable method. In some patients, 300 to 500 milliliters of dead space tubing may be necessary. It is not unusual to add several hundred milliliters of dead space tubing with only minimal increases in PaCO2, and then to have a marked increase with the addition of another 50 milliliters of tubing. Dead space tubing is reliable and predictable only with a control mode of ventilation. Dead space tubing is contraindicated with augmented ventilation. If the clinical decision is made to augment ventilation in a patient with acutely decreased arterial PCO2, this should be considered a reason for further adjustment in the pattern or rate of augmentation. In our experience, it is seldom necessary to abandon augmented ventilation because of the patient's desire to maintain a low arterial PCO2. However, it is also our experience that primarily central nervous system disease patients are usually best supported with CMV. Pharmacology for ventilator maintenance. Pharmacologic intervention is indicated when CMV is desired and the patient fights the ventilator. The ideal drug to control ventilation would possess a minimum of 8 factors. A minimum of 8 factors. 1. Have a potent central respiratory depressant effect. 2. Have minimal cardiovascular side effects. 3. Have potent euphoric effect, making consciousness tolerable during the ventilator course. 4. Have an analgesic effect or analgesic effect, since it is not uncommon for these individuals to experience pain. 5. Be totally reversible by a pharmacologic agent without dangerous effects of its own. 6. Be inexpensive. Ding! You have to drop a pin there. This is very important about giving care and being able to administer the care effectively. Especially when you're looking to help the masses of people. Number 6, again, be inexpensive. 7, be clinically familiar to nursing and physician personnel, harmonizing with your surroundings. 8, have a long table shelf life. There are drugs available that come close to meeting these 8 criteria. The best example is morphine sulfate. Here we go. Morphine sulfate. Morphine sulfate, the prototype narcotic drug, is a very potent respiratory depressant. It has few clinically significant cardiovascular side effects when the patient is well ventilated, well oxygenated, and in acid base balance. The only significant direct cardiovascular effect of morphine sulfate is on the venous system, where it causes a decrease in the state of venous tone. Much misunderstanding exists concerning morphine sulfate because the classic pharmacologic effects are related to the spontaneously breathing patient. Yeah. However, these adverse effects of cardiac arrhythmias and hypotension are secondary to ventilatory depression, hypercarbia, hypoxemia, and acidemia. In the well ventilated, well oxygenated, acid base balanced patient, the patient on CMV, the only documented cardiovascular effect of large intravenous doses of morphine is increased venous capacitance. This can be readily compensated by appropriate attention to hemodynamic monitoring and fluid therapy. See Chapter 27. Morphine sulfate is a good euphoric agent and an excellent analgesic. It is completely reversed by naloxone hydrochloride or Narcan. Morphine sulfate is inexpensive. Is familiar in clinical medicine and has a long shelf life. Morphine sulfate provides the respiratory care clinician with almost perfect drug for sedation and control of ventilation. Of course, the patient must have reasonable blood gases and the airway established prior to administration of large doses of morphine. In adults, up to 80 milligrams has been administered intravenously in the first hour, and up to 20 milligrams each hour for maintenance without untoward effects. If the guidelines are followed, the only problem with administration of morphine is an increase in the vascular space, which is readily corrected with proper fluid loading. Our usual doses for cardiovascularly stable patients are 10 to 20 milligrams or zero point zero 0.02 to zero point zero 0.03 milligrams over kg. The first hour with 3 to 6 milligrams or zero point zero 0.05 to zero point zero 0.01 milligrams over kg every hour for maintenance. The decision to sedate a patient to accomplish CMV requires an increased responsibility to evaluate the cardiopulmonary system and tissue oxygenation status. Patients often fight the ventilator because of improper ventilation or CNS hypoxia. It must be understood that sedation is given only after a careful evaluation of the adequacy of ventilatory and oxygenation support. Peace, Lucy. Hi, it's heart love. Thank you. What's good? Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're in the 23rd chapter. All those reading along and aspiring rep techs and M techs, nurses of all kind, OR techs, doctors, taking the MCAT. This is information for the next generation, uplifting them up. So thank you so much for being here. We're pushing towards 600 subs on this quiet, peaceful part of YouTube where we read books and learn from masters. So thank you so much for the likes and subs. Peace and welcome. Heroin has proved itself superior to morphine in Great Britain. This is probably because of its superiority as a euphoric. The agent is not clinically available in the United States. Mepar- Meperidine, meperidine, hydrochloride or Demerol may be used, but it is not as good a euphoric as morphine, and therefore does not work as well in conscious or semi-comatose patients. In our experience, none of the narcotics available in the United States have any advantage over morphine sulfate. Tranquilizing agents. In the middle of page 353 in this 23rd chapter, there are many experts in respiratory care who prefer the use of tranquilizing agents to that of morphine for CMV. Others use combinations of morphine and tranquilizers, thiazide agents, e.g., chloroprom- chloropromazine or HCI, thorazine, gained popularity for a time. The problem is that these drugs are vasodilators, perhaps by virtue of their alpha blockade effects, and may cause significant hypotension. Droperidol or inipsine or inipsine is a long-acting tranquilizer that may be used in conjunction with narcotics. This is popular in anesthesia and as a mixture with fentanyl citrate. Sublimase is a marketed as Inovar or diazepam. Valium has gained great popularity, especially as an adjunct to augmented ventilation. The greatest objection to the tranquilizing agents is that they are not predictable central respiratory depressants, and they are not reversible. Very key, because that was one of the eight guidelines that we're looking for in the medication, right? In the pharmacologic agent. Thank you so much for being here in this part of YouTube where we read books and learn from masters. This is high level, and I know it. I will put the vocabulary in the description when it's completed uploading. Here we go. Bottom of page 353. Paralyzing agents. The nicotinic portion of the parasympathetic nervous system includes the motor nerves to skeletal or voluntary muscles, including the muscles of ventilation. An impulse travels down the motor nerve to the nerve ending, which lies in close proximity to but does not touch the muscle cell membrane. The space between the end of the motor nerve and the muscle cell is called the synaptic cleft. Ding! The synaptic cleft is a big pin right there, describing how the central nervous system works in the synapses and then going to the dendrites, right? We're getting into it. I love anatomy. Thank you so much for reading with. I love anatomy. I hope you do too as well. All those reading with us and or in the replays. It's so delightful to read and master thyself, right? When we master thyself, thou shalt know the whole world. So it's important. All right. Again, I'll read this part, this section, and then we'll close out. It's been a beautiful reading. The space between the end of the motor nerve and muscle cell is called the synaptic cleft, and the entire area is known as the myoneural junction. The electric impulse travels to the end of the nerve and causes the release of acetylcholine, which travels across the myoneural junction and attaches to receptors located on the muscle soul plate, a portion of the muscle cell wall. The attachment of the acetylcholine molecule to the receptor causes repolarization of the cell wall, which leads to an intracellular biochemical process that results in contraction of the muscle fiber. An enzyme or cholinesterase present in the extravascular fluid metabolizes the acetylcholine, allowing the muscle cell wall to repolarize. The circuit of electric impulse, chemical release receptor depolarization, chemical metabolism repolarization occurs very rapidly and allows normal skeletal muscle actions to occur in response to motor nerve stimuli. Pharmacologic intervention at the myoneural junction can lead to muscle paralysis. And we'll pause right here in this beautiful chapter. When we reconvene, chapter 23, it will be episode 61. Thank you for reading in chapter 23 with us. Starting it off. We're doing wonderful. Thank you so much for reading here with us. Love to all the light workers around the world doing the work to help get the people into better positions. And with that, I want to speak about the grocery giveaway here today in South LA Cafe. It's absolutely beautiful. We did it. Pushing the 300 grocery giveaways here in South LA Cafe every week, every Wednesday. We had the beautiful, magical meditation with Lorianne Speed, shaking it up. It was so masterful. So, I want to leave you with this. Keep reading, keep writing. We're doing it. We're at the highest level and keep going up. So, I honor you, all the book lovers community, all our friends and family. I love you so much. Thank you for being here and visiting in this beautiful, beautiful energy. So let's have a glass of love water, live libation. As we know, D'Angelo is traveling for 40 days, 40 nights. I love you. Did a beautiful, beautiful song with the great Lauryn Hill. We honor you, called Nothing Even Matters But the Love and the love we have for one another. I love you, love you. Love you. I love you. I love you. Thank you to all our friends and family, all the book lovers community. We honor you coming on here, making sure we give you a part of this piece. So thank you for being here and loving with us, reading with us, and breathing with us. Just wish the best for all of us. That's why I come on here, just to give you a glimpse of the peace that we've cultivated. Highest heart love. I love you. I love you. I love you. Yeah, you know, 'cause I love myself. Stay honorable. Remember, There's no skipping level. The righteous path is always in front of us. Give your best, like my mom always tells me. That's why I'll reconvene and do a reading again, because my mom always told me to give my best. My dad always wants me to give my best. I love you, all my friends and family. Highest heart love to all the beautiful birthdays coming through and shining. Love to all the light workers. We're shaking it up. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Thank you so much. Shaking it up with us. I will see you soon. I will put the vocabulary in the description. And I wish you have a wonderful evening. We are going to the purple cloud tonight. Yes. We're going to the purple cloud. We have another Your Healing session tomorrow. And oh man, it's going to be great. His hand is opened up from the stroke paralyzation on his left side. We're just going to keep getting better. All right. And we'll see you soon. Peace.